Katie Harper with our pharmacy team, who's helping lead these efforts on doing these lunch and learns, which we've gotten some really great feedback on thus far. Today we're talking about GLP-1 clinical pearls. So hopefully there's some takeaways from Julie and Katie that you guys can get today. If you have questions while they're talking, please feel free to pop them in the chat, and I'll monitor that and they'll be monitoring that as well. So hopefully one of us will be able to answer you, and I'll have it recorded in case you need to reference later. And if you have feedback or other topics you would like covered in the future, please keep sending those to us too. We so appreciate it. So on to Katie and Julie.
Thanks, Dr. Bacigalupo. I will hand this one over to Julie to kick us off.
All right. Can you guys hear me okay, Katie?
Yes.
Okay, great. My name is Julie Pruitt. I have the pleasure of serving a couple of primary care clinics within the Cone Health Medical Group. GLPs are such a hot topic. Allison Marsh, one of my teammates out there in Burlington, will be joining in the presentation and help to make this such a great presentation as well. So she'll be taking over some slides and we'll wrap it up. And you guys just let me know if there's anything in the chat. But we wanted to focus this on GLP-1 clinical pearls within primary care, things that we deal with day to day. And wow, what an exciting landscape pipeline, but it's also frustrating too. And so we understand. So we wanted to kind of show you what's new, what's coming, how to navigate that, how to counsel patients better, and then access is always a hot topic, okay? So in the pipeline, what we're seeing is some exciting multi-peptide combinations. So not only do we have the dual agonist with the GLP and GIP in medications such as Mounjaro or Zepbound, we're also adding glucagon to the mix of that. So we're going to see a new formulation with that come out next year from Lilly. So that'll be in the next slide. But we're seeing greater weight loss with more and more medications that are coming out with these multi-receptors, and better metabolic outcomes too. So it is very exciting. Also, we're shifting to oral formulations. So we are seeing this take off. I know you guys have already seen Wegovy pill, and now we have Foundayo. But what we're seeing is improving convenience for the patient. You know, the cash price at the pharmacy is somewhat decent. So we're expanding access to that too. Access and cost is always hot. The topic is always hot. So we're seeing that change from day to day too. So we know that's very frustrating, but we try to stay up on the latest, greatest and how to get, the lowest cash price for our patients, and also utilizing home pharmacies for that too, because we're able to accept copay cards. So utilizing the pharmacist, for follow-up, GLP counseling and monitoring, access, we are here to help you with that too. So the rise of oral GLPs and next generation formulations, exciting this year has been oral semaglutide, which is the Wegovy pill. That provides a 13 to 17% average weight reduction from a pill. That's pretty amazing. This pill does have to be taken first thing in the morning, 30 minutes before the first food, beverage, medication. We want to separate that, with less than or equal to 4 ounces of water. So that is an exciting pill that can offer, almost similar to what the injection gives us. We're also seeing Lilly's new product, oral or orforglipron, very hard to say, or brand name Foundayo. And those trials showed us, an average of 11 to 12% average weight reduction. And this pill is taken regardless of food, beverage, that kind of thing. So it's a non-peptide formulation. So the absorption is, not dependent on those factors. So that may be easier for some patients. We love that this offers alternative for our needle aversion patients. It also offers a lower cash price. So a lot to gain in this market with these new oral options. So this is exciting. We also are seeing the higher doses of semaglutide Wegovy. High dose at 7.2. It sounds like a lot. We're at 2.4, right, with our weight loss and our MACE outcomes. But now we're seeing the 7.2 just got introduced. If you look at the trials, they're saying there's no more GI side effects. It's kind of hard to imagine, with our 2.4, we see patients struggle with that. But that step-up trial, the extension trial, showed an average of 20 to 21% average weight reduction. And this would be an option for patients, that have already utilized the 2.4 dose, but they've reached a weight loss plateau. And now we have somewhere for them to go. Price of this cash-wise is about $399, so around $400 cash. But again, if their insurance covers it, now we have somewhere for them to go if they've plateaued and do desire more weight loss. For those that have reached goals, their weight loss goals, we're seeing longer dosing intervals and more studies to come with that. So it's what do we do to maintain these patients? Well, I have some patients, extended out to 10 to 14 days, to stretch costs or just to maintain the dose. We're also seeing where trials now where they've been on the injectable and now we're switching them to the oral alternatives, which can offer lower cash price as well as some of the maintenance phase for them to enter in. So more to come with how to get these patients in a maintenance phase. Again, so much in the pipeline. So I wanted to just provide this, not to be overwhelming, but again, what is in our cardiometabolic pipeline? We've got our oral GLPs that we just mentioned. We're increasing access to these products. Also, like reducing the supply chain strain of our products like Ozempic, Wegovy, Zepbound, things that have gone back order before. Now we're kind of seeing that level out. Next generation, so out in the next 1 to 2 years, there's our retatrutide, the one that's the triple agonist I mentioned before. We've got great efficacy for that for obesity. We've got CagriSema by Novo Nordisk. They're combining another dual GLP for enhanced weight loss for that. And then Maritide is another dual GLP GIP antagonist coming out too. So a lot to come. We've got more indications. We've got Wegovy targeted for heart failure with preserved ejection fraction, as well as MASH. I've gotten a few patients covered for Wegovy MASH indications, which has to be well documented, but it is there, and we're seeing that that's making a difference. Tirzepatide, we've got for OSA, obesity, but they're looking at that. They say MASH is coming for that, as well as other metabolic benefits, so more to come. So the pipeline too is also focusing on minimizing muscle loss that we've seen with some of our current agents. So we're offering better efficacy in that arena as well as the continued weight loss. We always like to bring the up and coming things out, so not to make this more confusing, but it was Novo Nordisk's they are rebranding Rybelsus. So we are going to see Rybelsus kind of phase out, and then they just rebranded the name as the Ozempic pill. So it looks very similar over here. We see the Ozempic look just like the Rybelsus box did. Same administration. They reformulated it, so it looks like it's less drug that the patient's getting, but how to switch from them is the Rybelsus 7 and 14 tablet. Now we can easily transition them to the equivalent Ozempic 4 and 9 tablet. They are getting the same efficacy that they did, again, from the Rybelsus 7 and 14, now being Ozempic tablet 4 and 9. And Katie, correct me if I'm wrong too, this will be all updated and sent out in Epic when this does officially launch.
Absolutely. I was just typing that I'm working on a dot phrase to help everybody with this.
Great. And we did have, with the Wegovy pill and now the Ozempic pill, we did have the order built to say the administration there again at least 30 minutes before the first food, beverage, other oral medication of the day. Again, that water restriction is very important for that medication to truly get to where it needs to go and work with maximal efficacy that we want it to. Do not take with other liquids. We don't want to cut that in half. I have patients say, I cut it in half and took it with coffee. No, please don't do that because it really can work better if the patient actually takes that correct. So those will both be built into the new orders. It's already built into the Wegovy pill, but again, great counseling point that I think got missed when Rybelsus kind of launched, and we left that out. So these are the most hot topics we get asked about management of GLP-1s within primary care. One thing, contraindicated in patients with a personal or family history of MTC or in patients with MEN2 syndrome type 2. Now, that does not mean any other, thyroid cancer history, the papillary, If they are on Synthroid for thyroid, they'll bring that up, but that is not a contraindication. This is the only labeled contraindication to this class of GLP-GIP. History of pancreatitis is not a contraindication, however, rather a consideration. So say, a patient presents with a history of pancreatitis, they found the etiology of that, stop the offending agent or whatever was going on at that period of time. We have successfully, in conjunction with GI, re-challenged these patients, or we're able to successfully restart or new start those patients on the GLP-GIP medications, but it is something to consider in the patient's history. Consideration for women of childbearing age, we know that Zepbound and Mounjaro carry it in the label. So women of childbearing age, it does delay the gastric emptying. So with that comes, it can affect the absorption of oral progesterone. So at any initiation and dose escalation, they want to use a backup method to oral contraceptives 4 weeks after. So every 30 days, plus if you're going up on the dose, you need to use backup contraception methods. We know that fertility can return with, significant weight loss, and we need to ensure that these patients are getting appropriate counseling and appropriate contraception should be in place for these patients. Also, patients that are women of childbearing age trying to conceive, if they are on one of these medications, we do, the package insert actually recommends they stop the GLP 2 months before trying to conceive if they are able. Obviously, if they become pregnant and weren't able to stop it, we just want to stop it when we know that they are pregnant. So longer term risks of GLP-1s, we see a lot with the ophthalmic complications. So, we want those baseline retinal examinations, but, these patients that usually experience these usually most commonly have a high baseline A1C, as well as are on insulin, and that also have pre-existing retinopathy. However, it's prudent for all patients with type 2 on GLPs to have that annual retinal examination and explore and investigate any vision changes they're having during therapy. Love this wheel. So anything we can do to mitigate side effects, complications, and maximize weight reduction efficacy with these GLPs is so important to me. So I really, if the PCP is starting a GLP-1, send them to us for counseling, follow-up monitoring, send them to dietary or a dietitian to get that follow-up, because I think a lot of times we're quick to start these drugs if we're able to get them covered, and they kind of just get lost to follow up and do their own thing. But having that patient-centered approach is so important. So nutritional assessments, how are we managing GI side effects? We're trying to not have them start another medication just to mitigate a side effect, but do better in terms of eating, adding that water, adding those steps, prevention of nutrient deficiencies, getting that protein in, weight-bearing exercises to preserve muscle and bone mass. All of this, all of these things are really highlighted in most of the recent literature, because we're noticing, muscle mass is gone, concerns for osteoporosis. So those kind of things, we really want to do an efficient job of counseling patients on this. This is another, this I got from an article in JAMA Internal Medicine, and I love this for my patients. So you can see the healthy plate method to the right, and really enhancing that protein, getting the protein in. So 20 to 30 grams is where I, recommend patients do this. If they're not able to eat as much, protein bars, protein shake, somehow getting that protein in is so important for these patients. Snacking between meals, smaller meals, very important. Avoiding the side effects with constipation. Again, we're delaying gastric emptying, so we definitely want to be mindful of this. So increasing fiber, getting those steps in, staying hydrated. You have got to make lifestyle changes when on these medications, or the side effects will come. How many calls and triage do we get about this? So nausea, again, smaller meals, avoiding fried fatty foods, eating healthy, just doing better. These medications were brought to us, in the FDA with dietary and lifestyle modifications, not just a drug alone. Heartburn is going to happen. We've got the sulfur burps, but avoiding spicy foods, and again, those lifestyle and dietary modifications, we can help try to mitigate those. Again, we want to stay hydrated, the patient, and then getting that 150 minutes per week in. And it's interesting, a lot of these tips that are on this page are also required in the prior authorization. We'll mention at the end of access, the patient has to do their part in combination with this drug, and that's where we have the most success for the patient. Allison, I'll let you take it.
All right, thank you, Julie. I am going to talk some about initiation considerations with GLP-1 agents. So thinking through the mechanism, especially as we're thinking about diabetes management, seeing how our GLP-1/GIP agents improve both fasting and postprandial glucose levels, especially with our weekly agents. With some of those daily or twice daily agents, we saw a big impact on postprandial specifically, but now we kind of see it with both. So a couple reasons for that being the glucose-dependent insulin secretion. So essentially the stimulation of those beta cells to release insulin, however, it is only when their glucose levels are high. So that's where we see that reduced risk of hypoglycemia with these agents. Another one of them being the inhibition of that glucagon production, the glucagon release from those pancreatic beta alpha cells, and then finally the delayed gastric emptying. So we typically think of weight loss and weight management with that, but also seeing how it's slowing the rate at which we see food move from the stomach to the small intestine. So it's preventing those blood sugar spikes following meals because we're slowing the absorption of the glucose down and reducing that nutrient absorption speed. Most of the time, this is not in of itself monotherapy a huge concern with hypoglycemia. However, when we have patients who are already on existing insulin or insulin secretagogue therapies such as the sulfonylurea, then we might need to consider, do we need to make adjustments to those agents depending on the patient specifically. So we'll talk about that in a moment. Julie, can you switch to the next slide for me?
Thank you.
This will likely need to be adjusted slightly as we see that semaglutide switching from Rybelsus to Ozempic in the name, however, the doses would be essentially the same as Julie had already mentioned. But I think it's helpful for us to look at comparative efficacy of these agents. A lot of this came into play when we were seeing shortages, which hopefully are not affecting y'all as much now. But helpful to have a visual of where do these agents fall on the efficacy scale. More often than not, we're limited based on what is covered by a patient's insurance. Right now, I'm sure a lot of what we're seeing for the Medicare population is the Trulicity being what they are on just because Ozempic is no longer offered for patient assistance for those patients. So knowing that Ozempic 1, essentially equivalent to Trulicity 4.5 on an efficacy front. And then seeing that Mounjaro down there at the bottom, I didn't even include some of those higher doses, but on an efficacy front, seeing that the Ozempic 2 versus Mounjaro 5. So something to keep in mind, and especially if you are trying to switch between agents, whether that be for tolerance reasons or you're trying to see if switching between, maybe you can have additional efficacy benefits, considering whether or not to do a lower dose, doing the comparative dose, or if they're doing well on the agent, maybe starting them from let's say Ozempic 2 and switching to 7.5 on Mounjaro, just depending on the patient and their specific factors. All right, so going back to the initiation of GLP-1s and what should we do and adjust with those other medications. The American College of Cardiology was one of the few that made kind of a statement of initiation with GLP-1s and adjustment of some of these other agents, which is a bit surprising to me. But they had talked about, specifically with sulfonylureas, thinking about down titration or potentially discontinuing these agents. So specifically 50% at least or discontinuing. Now this is going to be really patient specific. We have some patients who are well above goal with their A1C, so this may not be necessary for those patients. However, when patients are well controlled, or maybe their A1C would even be less than 8, we're thinking of our older adults who were worried specifically about hypoglycemia, considering discontinuing the sulfonylurea altogether if maybe they're not on a high dose, or at least cutting it in half. And then looking at our insulin agents, reducing the total daily insulin dose by 20%. So that could be split between the basal and bolus. But given some of those postprandial glucose effects, specifically thinking of things like the delayed gastric emptying, so seeing some potentially postprandial hypoglycemia in combination with a postprandial glucose agent or insulin agent, I apologize, it might be beneficial to target that one first and reduce the dose by 20%, especially if they're already close to goal. And then additionally, monitoring glucose levels specifically in those first 3 to 4 weeks of therapy. This would be where maybe if their insurance covers it, thinking of a continuous glucose monitor. And now we're seeing that the state plan is picking up the CGM agents for patients not on insulin therapy. So that could be definitely a great patient to start on a CGM if you're starting them on a GLP1 and they're not already, then they're not on insulin. So had not been covered in the past, but a good consideration there.
Great, thank you, Allison. Now, I hesitate showing this slide because it can change tomorrow with GLP-1 access, focusing on cash pay, because it's great if the employer covers it. You know, all of these products mentioned for type 2, obesity, OSA, MASH, they usually are capped at a $25 copay, again, commercially insured that are covered. You know, at Cone Health, our benefit does not cover the obesity. So great options could be the oral agents coming in at $149 a month, maxing out at $349 a month. And our pharmacies here are, you know, geared to support us with this with copay cards. So, you know, partner with your pharmacist and Cone Pharmacy. We can help these patients, you know, try to get the lowest price. So, you know, and looking back, so Wegovy PO, Foundeo PO, Wegovy had a little bit more weight loss associated with that trial. However, Foundeo, you don't have those restrictions on when and how to take it. So matching kind of those oral options with your patient specific scenarios is how I approach both of those medications. With the injectables, we're still higher, but however, it's come down a lot from the $1,600, you know, price listed years ago. So the Wegovy auto-injector starts at $199, then it jumps all the way, you know, up to $400, just depending on, you know, if they're on the higher dose. And again, we've got that 7.2 high dose that's now offered. I did include the pharmacies where these are prescribed because that is, again, really confusing right now. But you can e-scribe it in Epic to NovoCare. And NovoCare takes care of calling the patient, getting that discount built into it. Or if the patient prefers a local pharmacy, they must have that either GoodRx or TrumpRx coupon. Either of those work, or the coupon through Novo itself, but it has to be called in to the pharmacy. And most times the pharmacy does have to order the product. Those have been a few of the snafus I've encountered with calling it into the local, but that is perfectly an option too. The Zepbound vials, we've got the vial and the new quick pen. I've actually just switched a lot of patients to the quick pen. And where this may be helpful is number one, less waste. So I love when we don't have to waste, you know, all these different plastics and pens. So a quick pen offers 4 weeks, so 1 month of our Zepbound. Again, in a pen. It comes with the pen needles as well. You don't have to e-scribe those because I have had patients, you know, if they have a vial and they drop it, that's a lot of money wasted, or can't really see the syringe lines when they're drawing up. So the Quick Pen's a great new option, and it's the same price, so $2.99 for the starter dose, maxing out at $4.49. Again, Lilly Direct and Amazon have partnered together, so those you can e-scribe to an Epic as well. for the Zepbound products. And again, all this is cash. Ozempic has surprisingly, lowered their cash price to kind of compete with the Mounjaro market. So they're starting at $199 for the first 2 fills, maxing out at around $500. Again, this is going to go to NovoCare or local pharmacies with the appropriate coupon. We're happy to help navigate those situations. I did include generic Victoza because I mean, people have forgotten about it, and I can see kind of why. If you've got Ozempic at $199 for once weekly and you're going back to a once daily with not as much efficacy, but again, that can be an option for patients maybe that just want to do that. That is there for them. So going through, what are the patient's goals? How much weight loss are we looking at seeing? Are we in the maintenance phase? Can we go to an oral option? So now we have a lot more options for patients. And again, Cone pharmacies and pharmacists here are happy to help partner in making sure the patient gets the right medication for them. Medicare Bridge program for obesity access. This has been a hot topic in the news. So CMS announced the balance model. So again, for Medicare patients focusing on lifestyle and nutrition and comprehensive health, they are starting a bridge program come July 2026. And I know Katie, they've been researching what this looks like, how this is going to work for patients, because I feel like it's just going to be a big thing. So with some Medicare beneficiaries, they may see lower costs around $50 a month capped for obesity medications by mid-2026, that being July. So eligible GLP-1 drugs under the bridge include, again, the products for obesity. So you've got your Wegovy injection in tablets, you've got your Zepbound, and then now you've got the Foundayo product as well. Now, it does note that beneficiaries already using GLPs for other conditions such as type 2, they will continue to access them via their Part D plans. This is something separate, just focusing on obesity access, bridging them to the balance model that starts in 2027. So there will be more to come with this piece. Some prior authorization documentation tips. I think in the chat, Katie mentioned we are working on dot phrases. They are coming. I know providers are getting a lot of pushback from the prior authorization team, mainly because of the insurance. So making sure we're documenting appropriately and jumping through those hoops that they make us jump through, it can be very challenging and frustrating for everyone involved. But just a couple of quick tips that have really helped me when I'm building my progress note or knowing that a PA is coming. So noting documenting that baseline A1C, we need to see where they had the diabetes at diagnosis, no matter what the date of that is. We really need to include that in the note somewhere to say, hey, this patient's not 5.5. They do need this medication. They do need to continue on it to maintain these results. Documentation listing initial and continued dietary and lifestyle modifications. The patient is working along with the medication. It's really important to notice the trials, the failures, intolerances, and contraindication. That's just really helpful to copy forward so we're not wondering, oh, well, the patient needed step therapy. They should have tried metformin first, or it doesn't cover Mounjaro first. We have to try 2 out of 3. So noting this somewhere in the note, or at least the allergy and intolerances tab on your left-hand banner in Epic, really helpful to note those medications there so it can be quick and easy for the PA team to get that prior authorization approved. If for obesity and OSA, what we're seeing the insurers come back and say, we need that weight and BMI within 45 days. That patient can't MyChart in and say, hey, I need this for Zepbound for weight loss. They need to see you guys within 45 days of submitting that medication. The insurance is very strict on that. They need a 6-month follow-up. They need to be followed and monitored. Again, detailed documentation of lifestyle modifications at each visit. Even if they have OSA, it just needs to be followed through. And I mentioned in some previous slide that minimum of 150 minutes per week is some language they like to see, noting that they're, targeting a lower daily caloric intake. So making those lifestyle changes. One thing we've seen Medicaid do for the obesity products is a patient needs to currently be on and will continue lifestyle changes. AI is actually looking at that exact phrase. So we need to build that within our notes too. And I know that's going to come with the dot phrase as well. Zepbound OSA has to have a positive, moderate OSA sleep study. Now we've seen insurers say it has to be within a year. We've seen some, except one that's 5 years. We just don't know really until we submit it, but it is helpful to have an up-to-date, positive, moderate, having that greater than 15 events within the sleep study. These are all helpful things that help to get the prior authorization approved as painlessly as they can. So I guess we'll take any questions or comments. Thank you so much.
We do have a couple of things in the chat. I'd ask any other physicians to weigh in on Dr. Matthews's point. I was on the other night too about kind of the conversation about coding and documentation accuracy for obesity. And so kind of balancing that with recognizing that documenting at least someone's baseline BMI in the note is also really helpful from the access perspective. Does anyone have anything to kind of say from that perspective? Should we use the old BMI as the diagnosis, or is it
I was
Dr. B?
just typing
Yeah.
him a reply as you were talking, Katie, but
Thank you.
To capture both needs, you are supposed to update your diagnosis as their BMI changes, right? So if their BMI changes to a 29 from above 30, you need to switch to overweight, not obesity. But you still put their starting BMI in the plan of that problem so that they have it for prior authorizations, because often that starting BMI is the helpful bit for the PA. So just update your diagnosis still, like the HCC team says, but keep it in your plan.
Charlotte, your question about what if the pharmacy says a GLP is covered, but the PA team states it is not covered. I'm not sure what could have caused that discrepancy. That would be one that I would loop in your clinic pharmacist to kind of figure out what might be going on with that. Joy, getting pushback on the PA for Zepbound for sleep apnea. Often told Wegovy is preferred. I think oftentimes plans will kind of put both of those in the same bucket, even though obviously you're right, the Zepbound is the one with the diagnosis for sleep apnea. I think that is one that pursuing the PA with the sleep apnea diagnosis would be worth doing. And again, if there's any sort of issues with that, loop in your pharmacist so we can help kind of navigate the coordination between the pharmacy, us, you, the PA team. I'm not sure. Can someone comment on Dr. Panache's question about our nutritionist referrals covered if the patient is not diabetic?
That depends on the insurance plan.
Mm-hmm.
So like Medicare is really specific about what they'll cover nutrition referral for. Diabetes and ESRD are usually the top ones that they'll cover that for. But private insurance is it's super variable, like everything else with private insurance.
Thank you. For Dr. Cox's question, I myself haven't done a ton of Zepbound. Do any of my pharmacists on the team have any insight about if the most recent sleep study is good because they're treated and how that plays into access?
So I haven't encountered that. I've just had the initial sleep study that diagnosed them with the moderate greater than 15 events. And then they start the therapy, but they haven't had the repeat study controlled. So I haven't had any experience with that specifically. But we definitely have to have that initial study, unfortunately, to have that documentation that was there. And they are very strict on that.
And I talked to a sleep medicine physician about this recently, and we all have people who have been on a CPAP for decades, right? And may not have great access to their initial sleep study. And yeah, if you get a sleep study on them now on the CPAP, it'll look pretty good. Hopefully it should look good. And so they've actually had people who we know have sleep apnea, who use a CPAP, do another sleep study without their CPAP, so we can capture again how severe it is, and that's how they're able to get Zepbound for those folks. So, oops,
Yeah, I'm a sleep provider. I'm one of the sleep physicians. I can answer that. You don't need a follow-up sleep study to keep while they're on CPAP to keep the authorization for Zepbound. You don't have to show that they're getting better on the CPAP or not. You just need a baseline sleep study. And yes, I agree that when we don't have a baseline study, we just ask them to do a home sleep study without the CPAP for 1 day, and then we can get the prior auth.
Right.
That's helpful. Thank you. About the counting clicks with the quick pen, it's actually really interesting how they did the Zepbound. They don't have the dose marker on there. It's just 0, and then you click a lot to get up to 1. And so that's one piece interesting for patients is even though the script may say, inject 5 milligrams, they're not dialing to the number 5, they're dialing to the number 1, which can be a little bit confusing. You can count clicks. Unfortunately, most of these kind of cash price programs are really smart. And to maintain the lowest price, you have to fill within a certain number of days. So you can't stretch the supply, or the patient can't stretch the supply by kind of, dosing less. The other thing, Julie, I didn't think that the pens came with pen needles. I thought we had to prescribe those separately for the Zepbound quick pen.
Last time I sent one to Lilly Direct. They tagged on
Okay.
$5 for the
Yep.
needles,
Yep.
and I didn't have to send them. They just called the patient and told them they were doing that.
Correct.
But we
I think
can verify that too.
Yeah, Lilly Direct will add it and charge the patient. I think if you were filling it someplace else, we would need
You
to
may
do the
need the
pen
pen needles.
Yep.
Okay. And that pen does need to be primed with every
Yep.
dose. But like you said, I know somebody could get smart, dial up and divide the clicks and figure out the dose. But yeah, not recommended for that. They do have to order every 45 days as of now. But also another tip I'm telling my patients, especially, Cone employees, load your HSA for next year, plan ahead. That's helping, with tax deductions as well, but planning ahead for, something like 150 a month can be a lot more feasible for access to, cardiac outcomes. Wegovy pill has that the MACE data. So we're seeing those come along too. So that's kind of encouraging to see for some of our fellow Cone employees that are, itching to get on some obesity treatment.
And then Julie Allison, Dr. Cox is asking, can you review the change in Rybelsus to Ozempic pills? Are they made differently now?
Yes, they did formulate that differently. So it looks like less drug is in that, but what they did, it's a brand new formulation called the R2 formulation. So they got smarter with how that's being absorbed. So it looks like less drug, but again, that 7 to 14 of Rybelsus is the Ozempic 4 to 9, but they enhance the bioavailability. So in practical terms, it means the body absorbs the medication efficiently enough to deliver the intended effect at lower milligram strengths.
And I think overall, I would agree in the chat that it's very frustrating. A lot of plans are still not covering things for patients that qualify for therapy and meet clinical criteria. Dr. Cox is asking, how does the glucagon part of the triple therapy work?
So it sounds counterintuitive, right? It does when it first came out. I was like, what in the world? But it's really, these work on the postprandials. So it's really dependent on, what food is coming in and how that glucagon works. Does it need to lower the blood sugar? Does it need to, come and cover it? So that's how that kind of works to add to that triple effect with the dual like GLP, GIP mechanism, if that makes sense. Oops, sorry.
This is great, you guys. Any other questions? And obviously, as you think of other things, please reach out. We're happy to help. We're all frustrated in this space, but excited in this space together. Thanks, everybody.
Thank you.
Thanks, Julie and Allison. You did a great job.
Thank you so much.